All right, Brian, let's talk about tennis elbow.
Oh, tennis elbow. I'm quite excited because I've been using a mobilization with movement technique for 20 years and before any scientific proof appeared. And you can tell them about that because you know about these references. But I found years and years ago what was seemingly a muscular or musculotendinous problem called tennis elbow. I found that all the signs and symptoms would disappear in chronic tennis elbow if you repositioned the bones of the elbow. They had no pain at all. And I used to treat my patients, have success, and you just tell them just what's happened as a result, scientifically.
And it's interesting because it doesn't really actually make sense from a perspective when you're working on the lateral elbow that if you do a lateral glide, it would stress those tissues even more so, and it should cause an increase in pain. And in fact, the pain is often abolished, isn't it?
Yes.
Well, Bissett and et al. In 2006 came out with an article in the British Medical Journal, and those of us who can speak the King's English, for you type people with that funny accent, I think you read it, and it said that it is effective. In fact, it's more effective than injections,
yes,
and then wait and see or no intervention.
Yeah.
And so we do have that evidence, and we also have a new piece of evidence that is a clinical prediction rule by Vincentino and friends who got together, and it has very good ratios that it says between 79 and 100% predictability, probability of these mobilizations with movement being effective in the particular type of age group that they studied. So it's something worthwhile to look at your references, and the references, of course, will be in the handout.
In the handout, yeah. Yes, this mobilizations with movement. If you think about it logically, if you had an athlete who had developed a tennis elbow playing tennis, they're young, they've got a perfect circulation, they're healthy. Why doesn't it heal spontaneously? Why is it that sometimes 6 weeks later, 2 months later, 3 months later, they still have the signs and symptoms of tennis elbow? If they had a soft tissue lesion, you would expect them to be a cadaver if no healing had taken place. And these people have still got it. So what's going on? My belief is that when you've got a problem with the musculature down here, the extensor, and you've got some damage to part of that as a result of playing tennis or whatever, every time you're using that hand, these muscles are not synchronizing anymore. Some are out, not functioning. And I think that brings about a positional fault in the elbow. Does it? Well, we found by repositioning the ulna on the lower end of the humerus, the symptoms disappear. What symptoms? If you've got tennis elbow, the tests for it, usually with an extended elbow, gripping hurts. Gripping, again, with extension hurts. Some are so bad that just extending fingers hurt. Now, all these signs and symptoms, you should test if you can alter or get rid of them by doing a mobilization with movement. And if you can, then you show the patient what to do, and you get a treatment regime underway, and you'll have the same success that they had in that study published in the BMJ.
Can you show us how you would manually approach the
Right, Jules comes in, I've got pain here, it's been here, I've had it before, it's come back again and again, and I've had it now for 6 weeks. And if I'm here, I'm fine, and here I'm not. So the first thing I do is to get hold of the elbow. I locate that part of my index finger, right where the joint is really, isn't it?
Right, the MCP joint.
Yep. I locate it on the upper end of the ulna, and I fixate above the humerus. I ask Julie to pronate her forearm. Now, while I reposition the ulna, she grips.
And the direction of your force is towards what bony landmark?
Well, it's really, you could almost say the epicondylitis. It's really coming straight across. It's a transverse translation.
Great.
Now, you'll find when you're seeing real patients, you'll turn them over, you'll do that, and they'll say, oh, that's better. Better is not good enough. No. If they say it's better, you adjust your direction, only again imperceptibly, until it's gone. And if you can't eradicate their signs and symptoms by doing this, you're not going to use the technique. So there we are. I move it. Jules says, oh, that's better. And I do that. I've changed. You can tell I've changed, but no one looking at the screen will know. But there are those subtle changes.
Now, this is lateral elbow pain with gripping. Now, would you always treat them in a pronated position or a neutral position or a supinated position?
You sometimes find with quite a severe chronic tennis elbow, you cannot turn the pain off in that position. If you put them in supination, you've got nothing to treat. They don't have symptoms with a real tennis elbow. It's only when the arm's pronated. So that's your start. If you do that and you have no luck, just flex and see if they have pain there. Now, sometimes, instead of pain with full extension, that pain comes in when they're here, in about 40 degrees or 60 degrees short. So that's your starting position. So Jules would be there. If she's got pain there, we will reposition. Now you try it there. And you'll probably find you fix it. And when she does her repeated exercises with mobilisation, with movement, as the days pass, that's gone, that's gone. Now it's only present in extension, so she treats it in extension. But as a treatment, as a therapist, I would lie the patient down, I would apply a mobilisation with movement, and I'd give her repetitive exercises, strengthening exercises for her hand. I might do 3 sets of 10. And after each set, when I stop applying the mobilisation with movement, it should be, hey, that's a bit better. Second set, hey, that's a bit better. Third set, hey, I've got no pain. So can we show that lying down, how I might do it, and then we will show Jules how she's going to treat herself.
Right.
Because in the study, the patients with chronic tennis elbows saw the therapist on 6 occasions. They saw the therapist on the first week twice. They saw the patient on the first week twice. They showed the patient what to do and checked that they were doing it correctly, say 2 or 3 days later. And then they left them for a week or two, and up to 6 weeks. And all these people in that study at the end of 6 weeks were pain-free.
Right.
And they were a year later. So that's exciting.
Right. It's a combination of clinic treatment and home exercise program.
Yep. To make sure they've got it right.
Right. Well, let's take a look at that on the table.
Yep.
So, Brian, as we start doing the tennis elbow technique with the belt, I'd like you to explain why you're using a belt. And once again, I want to remind the people watching that you're not using the belt for the force that you can apply.
Yes. Okay, you have the patient lying, and as you can see in Julie's case, her hand is pronated, because in that position she'll probably have her symptoms. Now, the technique I'm going to show you is how I, years ago, would treat my patients, till I taught them to do their own treatments. But it's also the technique you use if you are small in size and you've got some great big giant of a man and you want to reposition his elbow to see if it stops his tennis elbow. And there's no way someone with small hands can deal with some great big football player. So we use a belt, and the belt is located right where the joint is. Now, you'll notice I bend over the patient. I'm hovering over the top. And when I start to stand up, I'm now giving this lateral translation, which we've already confirmed when she was standing, takes the symptoms away.
That's right.
Or if you're a small therapist, it's so much easier for you to be able to just lift that up using a belt.
And I'm in a good position to see the angle of pull, and it is straight out towards the lateral epicondyle if you maintain internal rotation of that humerus.
That's right. Now, I apply a distraction. As soon as I've applied that distraction, I will ask Jules, my hand down here is fixating, ask her to grip. Now, if she has no symptoms, I'm going to ask her to do this 10 times and do a maximal contraction. And every time you've done this, please wait a few seconds for the muscle to recover. Just don't go. And that way it's addressing the issue of weakness, and also it protects the musculature itself.
As you go ahead and perform about 5 of those gripping repetitions, I'm noticing another thing that might not be evident on the screen, which is the comfort of that hand. It's not grasping her hand, it's not squeezing her hand, but it's allowing a normal glide, but keeping the horizontal nature of the forearm,
Yes?
so that there's no tilt in the joint. It's just a pure glide.
Yeah. After she's done 10 of these, I'd let the pressure off and say, how does that feel?
Good.
And that feels good. She might say, that feels better, but I would repeat this 3 times, 3 sets of 10. And that's the advice I'm going to give her when she's doing a self-treatment at home.
And how would you resist wrist extension if you were doing this? And
Well, you can. You can put your thumb down there,
Okay.
clench. That's a good point. Now, extend your wrist.
so you can do all that with your hand,
Yes.
and that's
Yep.
another purpose for the belts.
Yeah. But
You
I
can-
don't concentrate too much on that, because when the patient is home, no one's there to
Right.
give resistance.
Exactly.
You've got to give them some function
Right.
to
And,
get some strength.
And we'll discuss that.
Yep.
Let me ask you one more question. If you get in position there, show us where we can go wrong with,
Oh.
with the angle of the belt.
Oh, you can go wrong so easily. First of all, instead of being directly above, you start this. It's no longer a translation. You will not clear the symptoms. You may find that as the patient's gripping, you move in this direction.
Yes, yeah, right.
And if you move distally or ventrally, you've lost again the translation. And make sure that this arm stays where it is. If while they're doing that they roll their shoulder out, as you can see, you've lost your translation. But that's to stabilise the upper arm. There's the distraction. There's the exercise undertaken by the patient. It's repeated.
And how would you make an adjustment if the pain occurred not in full extension of the elbow, but in a
Earlier.
flexed elbow position?
Therefore, we'd have to start in this position.
Okay.
In other words, if they have pain, normally they won't have pain in full flexion.
Right.
No pain. If the pain's there and not extension, well, that's where you're
That's
going
where
to
you
start.
treat. Yeah.
So you come out to where the pain begins, and you could start your treatment there with a very nasty tennis elbow that's hard to resolve. And on subsequent treatments and at home, they increase the extension and do all their exercises in full extension. And the paper and the patients in the study that was produced in the BMJ, the British Medical Journal, all the patients having our approach done to them were so content and satisfied. They couldn't believe, just by moving the bones of the elbow, their symptoms have gone. Now, while we're talking about it, while Jules is here, I did have a patient in Australia who had not responded with a chronic tennis elbow. And when I say chronic, this was a nasty one. This poor woman, any gripping anywhere was painful. This made no difference, the correction of the upper end. And just by chance, I got hold of her olecranon process. And I found that the moment I moved it laterally, she was symptom-free. The other techniques had not worked. She was delighted. So she now had a treatment she could do by moving the olecranon process across.
In essence, that was a rotation type
In a
of,
way, it's a rotation.
In a way.
Yeah, because that's not fitting in neatly. And it might be coming in, you needed some rotation, or it might need some medial or lateral movement just to line it up. But it's a very neat situation there where it fits snugly into that fossa.
Yeah.
You've got to get it right.
Let me just take the opportunity to recommend to the viewer that looking at the references and checking for example, the bmulligan.com website has a list of these references, and you can more thoroughly examine them at that location.
You can even bring the articles up now, can't you?
That's right.
Oh, yes. Yeah. And go through them.